I'm so honored to be here today. Thank you so much for having me, Dr. Parsad. My presentation today is about the efficacy and safety of using PRP in treatment of acral vitiligo. As we all know that acral joint areas are common sites of occurrence of vitiliginous lesions. They are usually more resistant to medical management due to low melanocytes density and greater chance of trauma, which can induce covernization. Phototherapy with narrowband UVB is the gold standard for treatment of vitiligo. However, the response may be slowed and delayed. Combined treatment have been found to be superior to monotherapy regarding efficacy and early response. PRP has been previously tried by some authors with varying amount of success in the treatment of vitiligo, but the data in its use in acral vitiligo is limited. So, in our study, we have attempted to analyze whether the addition of PRP to microneedling a narrowband UVB for the treatment of acral vitiligo provide any advantages in terms of the repigmentation response, and to determine the best treated sites at the hand and feet with this combination therapy. So, this study was a prospective experimental clinical trial performed in 42 patients attending Asyut University Clinical Hospital. The inclusion criteria are patients older than 18 years old with bilateral and symmetrical lesions, unresponsive to medical treatment or phototherapy for at least 6 months. Lesions should be stable for at least 6 months, and any topical or systemic treatment should be stopped for at least 1 month before the study. Exclusion criteria are those with low hemoglobin and platelet count, patients with active infections, history of keloids, hypertrophic scars, pregnant lactating females, and bleeding tendency. All patients were subjected to full history taking, including personal history and clinical history, then full dermatological examination and photography. Then lesions at the hand were classified according to their size into 4 groups: lesions at the dorsum of the hand, lesions at the periangual sides, lesions over the knuckles, and lesions in between the knuckles. Also, lesions at the feet were classified into 4 groups: the dorsum of the foot, the lateral side, and the left side. For each treated site, we have measured the extent, the point counting of the lesion, and the VASI score. Then the lesions on one side of the body were randomly allocated to Group A, which was treated with microneedling and PRP every 2 weeks, and narrowband UVB twice weekly for 3 months. The other group was given only microneedling and narrowband UVB without PRP. Then patients were assessed 1 month after the end of therapy for the percent of repigmentation, the percent of the VASI change, the reduction in the point counting, the color match, patient satisfaction, and any side effects were assessed. The demographic data of the studied patients shows that most of them were females, and about 64% have skin type 4. This is the clinical data of our patients. The mean disease duration was about 8 years, stability duration was about 17 months, the VASI score was 0.17, and the mean number of treated lesions was 4. We have treated 702 lesions in the hand and 67 lesions on the feet. Regarding the results of the treated lesions at the hand, the best treated site in Group A was the dorsum of the hand, followed by the area in between the knuckles, while the knuckles and the periangual were the least in response. Group B shows the same response, and when we compare between both groups A and B, we find no significant difference between them. The VASI, the percent of the VASI change shows the same results. The point counting and the color match all show no statistically significant difference between Group A and Group B. These are some of our selected cases. As you see, both Group A and Group B have the same results with improvement with and without PRP. Another case which show excellent result in one side with PRP and good result on the other side. This one show more or less the same results in both sides A and B with without PRP. Another case with fair results in both sides. Another case which show that the periangual lesion didn't improve in both sides. Then we have some patients treated at the feet, just 8, and the results were much less than those treated at the hands. The percent of repigmentation and all the scores were less, And also there was no significant difference between both treated groups A and B regarding the percent of pigmentation, the VASI change, the reduction in the mean point counting, the color match. I'll have two selected cases with poor results with my treatment. No correlation was detected between the age of the patient, the disease duration, stability durations, and the repigmentation response, although neither the sex of the patient or the skin type have affected the response to treatment. Side effects for treated with were minimal. Only expansions or copularization have been done in 2 patients. Patient satisfaction was more or less the same in both sides. So my conclusion, addition of PRP to narrowband UVB and microneedling has no significant advantages in treating patients with resistant acral vitiligo. The response to treatment is better in area with hair follicles at the dorsum of the hand and in between the knuckles, while areas over bony prominence like the knuckles and areas devoid of hair follicles like the periangular regions are more resistant to this combination therapy. So my recommendation is that we recommend further researches on a larger number of patients with acral lesions for a longer follow-up periods for evaluation the effect of different combination therapies. Thank you so much, and I'm inviting you to attend the next visit, inshallah, in Egypt, 2024. You are all welcome to attend it. Thank you so much.
Thank you. Thank you. Any questions? Okay, thank you.